Everyone for taking time out of your busy schedules to join us. Hate to break up the good fellowship that we're having here, but it's good to see that. This is definitely a very important time to check in with our friends and with friends that we haven't met yet. So it's really good to see you all tonight. Tonight we've got a great topic before us. We've got a great panel, and we have gone a little bit too long in the front end, so I'm actually going to be really quiet and sit down really fast. However, one thing I did want to point out, if you have not signed in, there's a sign-up sheet on the back table. The sign-in sheet will be important if you're going to be getting your ACHE credits. That's the form that ACHE uses to provision those credits. So please make sure you sign that. We will be sending out, following this meeting, I'll be sending out an email that'll have a link where we're going to ask you to go to and fill out a survey, just letting us know how you thought the night went, and it'll give you an opportunity to let us know topics that you would like to hear more about, and that'll be a great opportunity for us to hear your voice. Without further ado, I'm going to sit down. Go ahead and take off.
All right, well, good evening, everyone. For those who don't know me, which is probably most, I am Will Jackson. I am the Chief Operating Officer and Information Security Officer at Christ Community Health Services. For those who may not know who we are or what we are a faith-based, federally qualified health center. And so we're basically a medical group practice that receives federal funding to position ourselves in communities that are disproportionately disadvantaged with social drivers of health and access barriers to healthcare. And so we serve roughly 62 to 63,000 unique individuals between Memphis and now Jackson, Tennessee, every year, with about 212,000 visits across those organizations, 180,000 prescriptions. And so it's an honor to serve in this community. I've been here since April of 2019. And so thanks to something called SARS or COVID, I'm still learning Memphis. And so I'm excited to be here and to get to know each of you. And I'm honored to be sitting with such an esteemed group of individuals. One I know well, two I'm learning now. And so with that, I'd like to introduce our panelists, and we will jump right in. To my immediate left, we have the wonderful Susan Cooper with Regional One Health. She's the Senior Vice President and Chief Integration Officer. And so, Susan, I'm gonna do something a little different. I'm gonna allow you to take 30 seconds and just tell them what you want them to know from your Bible study.
Yeah, I have the greatest title because nobody knows what I do, right? Chief Integration Officer. But I'm responsible for population health and clinical innovation. And we have now a both nationally and internationally recognized program that serves our most vulnerable patients called One Health. And we'll talk a little bit about that. But by background, I have a nursing and public health background. Prior to coming to Memphis, I served as the Commissioner of Health for the state of Tennessee under two governors, and retired and came to lunch in 2012. It's been a very long lunch. So I've been here quite a while now. So Jim?
Thank you. Yep, we have, most people probably know Jim, but officially Dr. Jim Bailey. He's an internal medicine physician, and he's the executive director of the Tennessee Pop Health Consortium, which is one of the organizations that really helped me fall in love with what Memphis is trying to do with population health. And so with that, Jim, I'll let you say a little bit more about yourself.
Terrific. Well, first I work for Susan. Because I'm actually representing two organizations here tonight, both UT Health Science Center and Regional One Health are one of our most important partners historically, and have actually worked a lot with the organizations you represent, extensively with Methodist, with Baptist, with Christ Community Health Services. And I'm very proud that both UT and Regional One and your organizations are really committed to improving the health of our community, and we know that means reaching beyond our our hospital walls, right? And really reaching into the neighborhoods that are most in need and helping people get essential primary and preventive care. So those are the things that keep me occupied and interested in my day job.
Awesome.
Thank you.
Last but not least, the best shall be last. Dr. Meredith Ray from the University of Memphis. She's an associate professor in the Division of Epidemiology, Biostatistics, and Environmental Health, and also a master program coordinator for biostatistics, AKA another data geek. I'm excited, and so I'll let Dr. Ray say a little bit more about herself.
Yeah, so similar to Susan, I typically get a blank stare when I say I do biostatistics. Everyone's like, what? So I'm at the University of Memphis in our School of Public Health. I have been there since January 2015. And so I'm a little bit different role than the two to my left, and I think I might overlap a little bit with Jen. So I'm really here kind of representing more the academic side of the University of Memphis, and so I will be very clear if I represent my own thoughts. I can't represent the whole School of Public Health at the University of Memphis, but we do a lot of work. So with the academics, a lot of our faculty, especially in School of Public Health, we have dual roles. So in addition to teaching, as some of you have taken our MHA program, our faculty also are in research. So that typically tends to be either NIH grants or working with the community. I myself work with Baptist as well as some with St. Jude and Sickle Cell, a little bit with UTHSC, and typically collaborating with doctors at the institutions and helping them, for me personally, analyzing data, whether that be internal quality metrics or population level. It's a huge range. So, but other faculty members also are working with the community in terms of trying to help outreach and various fields across all of Memphis. So thank you for having me.
Well, we're excited, and we're going to jump right in. Today's topic is around service for our community, especially regarding community-based health or healthcare that's driving a change in the community. And Susan, I'll start with you because I think you can kick us off well with this first question. When you think about our community and community health, what would you say is the level of commitment from your organization to community health, and how is that commitment, how is it carried out in the communities in which you actually serve?
It's a great question. First time I've ever had anybody start with the actual question on a piece of paper. So, well, as all of you know, Regional 1 serves as the essential hospital for not just Shelby County, but the surrounding areas. Going out in the 150-mile direction, we service the Level 1 Burn Center, the Level 1 Trauma Center, the Center for High-Risk Moms and Babies. But we've had a long-standing commitment to most of the underserved communities here in Shelby County. I'm looking at it, my colleagues here from Regional 1. I'm looking at Brenda, who serves in the Hollywood and Guthrie areas. Again, high need, high poverty areas. You can think about our South 3rd Clinic, where this is an area that lost a lot of resources, and so by partnering with Regional 1, we were able to put a pharmacy back into that area along with our primary care clinics. But more than, and at our hospital, on any given day, we serve about 22% of our patient volume is uninsured. So this is a place where care is delivered compassionately, exceptionally, that we believe every person in Memphis, when we set up One Health, our vision was that every Memphian deserved great health. We didn't say health care, and I'm going to really pound that home, because you can't have great health if you don't attend to the social drivers that lead people to seek health care, to try to solve problems that are not health related, and then their health is impacted because they don't have the resources out in their environment. So I would say Regional 1's history here is the longest, oldest hospital in the state of Tennessee, has never varied from their mission of delivering compassionate care.
Anyone you want to add to that?
That's such a great response. I was thinking about how the partnership of our institutions, which has been so critical for UT Health Science Center in Memphis, but the other day it was pointed out to me that UTHSC has over 800 locations across the state that where our residents, our medical students, our nursing, pharmacy, physical therapy students are working with providers in the community. Here in Memphis, that's at Baptist, that's at Methodist Labonner Healthcare, that's even at Christ Community Health Services. So we're really proud to be a partner in this activity of trying to get care out into the community, out into the neighborhoods of greatest need, a partner with your organizations, you know, who are all very dedicated to that cause. So I think what's most exciting to me now is that the University of Tennessee, that's a big organization. We have 4 campuses across the state, you know, here, Nashville, Chattanooga, and Knoxville. Our new chancellor is really focusing us on population health across the state and is working with President Randy Boyd to talk about Tennessee One Health. And actually, Dr. Hargraves came to one of our health hubs, which is a way we're trying to work with the University of Memphis, actually, to get care out into highest need communities. And we'll talk a little bit more about that. But that's just to say, we are not just talking the talk, we're trying to be a little part of the answer. And we know it's a little part because it's an answer that requires us all, right? But the way the Chancellor Buckley has put it, Tennessee is what, 46th in composite health ranking of our citizens, and he wants to see our composite ranking move, and working together, that's something that's actually achievable. We have evidence-based approaches that can help get us there. So the Tennessee Population Health Consortium is committed to measurably improving population health and health equity. We're going to be talking about measurement. Obviously, that's something that takes us all. And I just want to add one other thing because I'm excited about it. I'm talking to social determinants of health. Our students came to us. Every 10 years, we have to have a theme for our school across our campuses for where we want to improve and strengthen what we're doing. And our students and faculty and administration ultimately chose social determinants of health about 3 years ago is our 10-year focus to really think as an institution and across our institution how we could contribute to helping our communities address the social determinants, social drivers of health that ultimately are at the root, right? We're not going to fix it always in the hospital, but you know, I think there's really a desire for us as a university system and to get more to the root causes.
Yeah, no, I mean, I'll add on to kind of both of what you touched on. I think you made a comment about, you know, the Shelby County or even the general Tennessee, our whole region really, it's not just Tennessee, but, you know, has such a population that is so diverse, disparities, you know, various social determinants that I can't tell you how many times we do faculty searches of people that are really here because, like, you know what, this is an area that needs help. And also not only if we can figure out a way to help it, whether it's delivery of care, health care, access to care, all of that, and then use that as a model for the greater U.S. And so that's where I think a lot of the, again, speaking for the faculty in our school, you know, I know our faculty are always interested in helping. That's what we're public health for. And so I know for us, you know, we're really here to help be drivers to, again, assist with that, whether it be helping identify measures and get focus groups and trying to, because how do you make improvements? How do you baseline, right? Or going in and looking at the processes, looking at the evidence-based care. So that's kind of what U of M or School of Public Health is our faculty are interested in, of helping and saying, how can we get in here to help facilitate, whether it be, you know, the other hospitals or other local, I've got a list of other local, you know, West Cancer Center, Baptist, Methodist, Campbell Clinic, youth villages, you know, everywhere trying to help. How can we assist? We want to, whether it be measuring, analyzing, you know, kind of the same thing you were saying. You've got to start somewhere to bring the baseline up.
Thank you. And so, and on that note, you know, everyone's teasing about data, so let's go. We, you know, at Christ Community, we live and we're entrenched, as many of you are, in those in our underserved populations with not just seeing patients in the superficial health conditions that they present, but they're symptoms of some systemic issues within society that these patients are facing. And so oftentimes, as the community, the healthcare community across the nation, even locally, dives and digs deeper into social drivers of health, it helps us really focus on some of the more root issues behind why we have patients who are uncontrolled hypertensives and it's not improving. Well, if I don't have, for example, transportation so I can get to a pharmacy, even though we have 5 pharmacies, well, we have 10 locations, then I might not be able to pick up that medication. And if a provider in Orange Mound says eat healthier and I don't have a grocery store because they took the last one on Tillman and Sam Cooper, then how do you expect for me to get something besides, you know, McDonald's or Taco Bell, which basically is not perpetuating the diet that was prescribed. So we're talking these social drivers, but we can't just talk about it esoterically, right? We have to quantify it. So Dr. Bailey, I'll start with you. When you think about data, what are some key data points that you measure, whether with the Population Health Consortium or with UT, around social drivers of health, so we can actually begin to quantify some of these systemic issues?
That's fantastic. You know, I would also, I'm really eager to hear everyone's response here. On social drivers of health, I have to say a lot of the focus of the Tennessee Population Health Data Network, we call it 10PopNet, has been on healthcare data. And of course that really represents the downstream consequences, right, of social determinants of health. And so, you know, the answer I was prepared to give was, hey, the key metrics we're focused on in our Tennessee Heart Health Network, which is our main statewide initiative, are blood pressure control, diabetes control, and smoking cessation counseling. Those are our big 3, you know, because we think that those are healthcare metrics that are among our most important, you know, getting to goal on blood pressure. But when you go that step back, you know, I personally think, and I'm less proficient, maybe even than y'all in the metrics, but I think some of the key metrics are around poverty, right? And around education, and then around housing, you know, particularly housing instability, all those metrics that we're trying to now gather as part of our healthcare data, but only about 1/3 of the health systems have them now. But I think housing instability, homelessness, education, poverty, you know, income information. What are the others that you guys think about at the top of your list?
Oh, that's a loaded question. So for me, so obviously y'all are both within healthcare systems. So I'm looking at this from an outside perspective where, to me, it's hard to work on a problem without having quantitative data. You know, without capturing, how do you know someone's having a housing instability issue without capturing it? So to me, it's just, you know, typically in healthcare system, you're capturing biometric data, right? You're capturing typical demographic, you know, blood pressure, but you're not capturing the full picture. So, you know, so that's the biggest thing, is even capturing data, reporting it, having a system, RedCap, Excel, physically a way to quantify these measures, capture them, and then also knowing how to use them. And then not only that, it's you know, I know we're getting into IRB issues, but it's typically kept within within hospitals. So now all of a sudden, if you've got people like at U of M who are wanting to help and wanting to research this, how do you then get the data? How do you access to data? So it's, I think, bridging the gap, not so much, I can't really comment on the exact measurements, I feel like that's a huge loaded question everywhere from, I deal with lung cancer, so here we're looking at, surgical resection cohort, or we're looking at screening, lung cancer screening, or the sickle cell. So again, how do you quantify, even though they're St. Jude patients, how are you looking at education metrics? How do we know they're missing days in education? So all of these things to make an impact, whether it be, again, the whole, any sort of disparity or outcome, it's, to me, again, being the biostatistician over here, it's somehow capturing data in a usable format and making it accessible, obviously within, de-identified, being able to quantify it, use it, not only within your system, but across health systems. I feel like that's something we can probably do better, again, within my knowledge, of talking between healthcare systems, of Baptist and Methodist and Regional One talking of, if you have a similar, if we're looking at, I don't know, people with high blood pressure who are housing issues and living in a certain region, are they even showing up to hospitals? And if so, why not? Like, capturing these metrics to me and quantifying what the biggest issue, I think, is to have, because how do you know it's a problem? How do you fix the problem without measuring it somehow?
Well, I'm just going to talk about One Health, and I'm not going to talk about healthcare data, but we actually do measure in 15 different domains. We've got a 5-year data set for our highest utilizing uninsured individuals, and we use a standardized tool that measures income, food insecurity, legal issues, identification, housing issues, behavioral health, substance use. I forget some of the 15, but when people enter the program voluntarily, we sit with them and we score them. It's a 1 to 5 Likert scale with validated descriptions of what it means to be in crisis and what it means to be self-sufficient. And then we utilize that data to build community plans of care that we work with our partners to say, we say to the individual, Mr. Smith, what's the most important thing to you? What matters most? And that's the first thing we start on. And so when you look at our 5 years worth of data, the things that show up are housing instability, but I was shocked, it's way down the list, right? It's not in the top, not 2 or 3, it's probably 6 down the list. Food insecurity, lack of insurance, we might as well go in and call it out. This is a state that didn't expand Medicaid. So insurance, medications, people not being able to get their medications, transportation, getting to and from. You'd be surprised the number of people that don't have a driver's license, who can't find their birth certificate. All of those things are things you need to be able to access these services that are out there. So I think coming up with a tool and a validated tool, and if you just want to start somewhere, you start with what CMS is recommending: housing, transportation, food, utilities, and interpersonal violence. There are easy tools to measure that, and then you can look at how you close those domains by interacting with your partners. And then, just one more thing, if you keep that data, then you can have those policy discussions with the leaders of Shelby County or the city of Memphis and say, hey, 44% of the people who entered the One Health program had a housing instability. And we work very closely with the Community Alliance for the Homeless and whatnot, but there's no housing stock in Memphis. So even if you want to put somebody someplace, you have to have a place to put them, right? It has to be safe, livable, and affordable. And some things may be affordable, but let me tell you, they're not livable. And we've got to do a better job of that. Sorry, I'm on my soapbox.
Well, if I can give a quick follow-up, because this is a great soapbox to be on, and Susan has championed the collection of social drivers of health data, along with driving the dream in our community and trying to make that the routine. We're actually following her good example in the health hubs to collect that same food insecurity, transportation, because unless you identify those issues, you can't help address them.
And the drivers are different, not by Shelby County all looks like this. If you look at South Third and you look at, Harbortown or Hollywood, the drivers are different, and you have to understand, not even at the zip code level, at the census tract level, what does that community look like? Because it impacts people in different ways.
And I wanted to point out, for all of your health systems, your electronic health records have these tools that are available that can be activated. So I think part of this is a call to our health systems to begin to more routinely collect that information. The Arizona self-sufficiency tool that you use, the Prepare tool, WellRx is another one that's short. There's some great tools out there. And I wanted just to follow up on the other thing that Dr. Ray pointed out, is this business of the importance of data sharing. You know, it's hard to do, right? It's something our team in the Tennessee Population Health Consortium and many of the people in this room have been really dedicated to, but it's really hard to do, to share data so that we can benchmark in our own community, identify our populations at highest risk, and look at all the services that they're receiving, not just from one provider, right? So that effort, I think, is so worth it. So worth it. And if you have an interest, I think most of your organizations are participating in the Tennessee Population Health Data Network. University of Memphis is a partner in the Population Health Consortium, and we're making it easier for U of M faculty to access that data, de-identified, or for certain IRB approved projects that are important to the community health and with the approval of the health systems, sometimes identified data too. But I think that data sharing gives us the capability to really identify the areas at highest need. And actually, one of your students is working with us along with your GIS team to map where are the highest need neighborhoods in terms of social vulnerability index, with the greatest population, on bus routes, and that have highest rates of obesity, diabetes, and cardiovascular disease. And you can imagine these hot spots start lighting up, but as one of our pastors that advises us said, you know, in Whitehaven now, there are more dialysis centers than there are primary care clinics. More dialysis centers than primary care clinics or primary care providers. That's where we are. And if we're serious about turning that around, it does help to have data and intent to work together, you know, as a community, with government, etc.
I feel like this group is helping me push my four-wheel button on the dashboard. We're about to go off road maybe a little bit, but within the context, I've got a few things I'll say and then share it in. I'm geeking out over here because I told you I'm a geek, so I got Power BI for our organization open up. So I was just thinking about what we were talking about regarding having a standardized tool to capture data. We use Prepare. What are those top things systemically that we're seeing? Number one is unemployment. 1 out of every 4 individual was unemployed in a rolling 12 months that walks in our door. Next one is no transportation. 1 out of 5 did not have transportation within a given year. Next one is no housing. 1 out of 5 at some point did not have any housing. Not unstable housing, not doubling up, but no housing within a year. And yet, less than 5% of our patients is officially within our person experiencing homeless population. 1 out of 6 actually at some point had no food for a sustained period of time. 1 out of 6, no food. Doesn't matter what you tell me to eat, I have none. And then the next bucket, which was interesting, no medicine or access to medicine. That's 1 out of 10. One of the things that they actually come in for us to help solve, and either they don't have the means or they don't have the money to get the medicine that they need, coupled with the adequate food that they need to have, perhaps with, when you're talking about compounding the issue, livable housing. And so I just wanted to give you all a little bit of perspectives around some of that data. One of the things that I found interesting coming from Louisiana is that Tennessee does not have a health information exchange. And so I believe in, you know, let's face these elephants head on. So I will tell you, just go ahead and put on record now that that's become a personal passion of mine, is to see Tennessee readdress a health information exchange. Because if we are actually going to drive statewide change, we have to have a statewide infrastructure. We have to have the skeleton on which we can put the meat and the muscle. Otherwise, we have disparate body parts that are not actually one body because we're disjointed. Why? We have no skeleton that's connecting and holding us together. And so, you know, I'm talking to the state primary care associations and others within Capitol Hill even to say, why not? You know, play my new guy card, I don't care. But I understand that we start down that path, and I think data drives decisions, but humans make the decisions. So let's help ourselves share data across our organization so that at least we can understand the picture that's bigger than just our community. And so, you know, got a little transparent there, but it kind of leads into one of those questions. You know, what is one of those personal passions that you have around community health that you're seeing yourself actively vest yourself in on a regular basis for our Memphis community?
Pick your poison on who you ask here. I've gotten deeply involved with the housing community. So that's not just Community Alliance for the Homeless, but it was the former Neighborhood Preservation Inc. And, you know, you kind of roll out from there to try to challenge some of the long-standing views. You know, I remember one of the very first folks we enrolled in One Health, and it's a gentleman that needed, he was living in a car, there's a whole long story behind it, but we applied for housing, they said he doesn't qualify. We knew he was eventually gonna qualify. In about 4 months, we'd be able to have an income source for him. So we said to one of the housing providers, said, well, we'd like you to house, you know, Mr. Smith, and they said, well, we can't do that. We just take government contracts. And I'm like, well, if I pay you to housing, right? What's the contracted rate? And that includes wraparound case management services. And they said, well, you don't do that. And I said, sure we do, you know. And, you know, for me, it's always, you know, ask forgiveness, not for permission, really. But it was the first time that we had challenged both the community around thinking differently about how you can provide services and who can pay for them. And so just if you think about housing, we first got involved. Who knew there was a group that met every Friday that talked about people who were homeless that needed housing, right? We didn't know that. We're a hospital, right? We think houses just show up. So we got invited, and then we learned what they needed to make their decisions, and then they trained one of our One Health team members on how to do the applications. So on Fridays, when they all meet, instead of coming up and everybody wringing their hands that you gotta fill out applications, you gotta have this stuff, ours was already done, right? And so then it facilitated us being able to house people quicker. That was one thing. Then Megan, who's our director of complex care, became part of the governing council for this group of community housing providers around Shelby County. Then our person who actually does the application now is on the planning committee at the Community Alliance for the Homeless, and I now sit on the board of the Community Alliance for the Homeless, because there are a lot of resources out there, but everything's so siloed, right? So there's a lot of work at the federal level going on to take an all-of-government approach that we could translate here to Shelby County to say, okay, if you're gonna write an application, you're gonna provide services. It's not just housing or just food, or you gotta use money for education, or this can only go to healthcare. It's how do you start thinking systematically to say, probably if a person is homeless, they probably don't have any food, right? And likely don't have any income, and may not have an ID. When you start layering all together, then you can make community-based change that really improves not just the conditions in which people live, but it becomes an engine in a lot of ways for the communities. It's almost a new economic engine. Health, I've always believed is that. I'm sorry, I'm done.
Man, Tim, I don't know if you can hear any passion on that.
I can hear passion, and see, the great thing is I know it's how real it is. And Susan Cooper and the One Health program. It's so much doing the right thing, you know, around giving people support in achieving their own goals. And like Susan, sort of my passion point is around using lay health workers, people from the community, to bridge that gap between these systems and systems of care, which can sometimes depersonalize and not treat people with the respect they deserve. So a lot of my career, like Susan's, has been devoted to using community health workers, health coaches, and deploying them in a variety of different settings. We are now working with a number of insurers, with Shelby County government, with Regional One, with Christ Community, on a neighborhood health hub initiative, where we're extending primary care into the community by setting up little bitty mini clinics, in a sense, that are fully staffed by health coaches, that are people recruited from the communities they serve, and who are trained in evidence-based empowerment approaches using motivational interviewing, you know, that really great counseling approach to help people reach their own health goals and help connect them to the services that are needed. So it's very much the same sort of model as One Health, but we have opened our first health hub in Uptown, which is one of our most at-risk neighborhoods, and a second is about to be opened next door to Christ Community with as a Shelby Cares facility. So it's really been exciting to see Shelby County government get behind that effort. But we need, as my friend Alfred Stewart says, no wrong door, where people can enter in any of our institutions and get the support and help they need. And it's most often not from a doctor.
And we need to quit calling people names. I mean, come on now, you know, you've all got them, right? Let's just put it on the table. They are frequent flyers, super utilizers, my favorite, non-compliant, right? Let's think about that. And that's because the goals of a health system and the goals of the person are often misaligned.
Right.
And we never say, you know, what is it for you, your idea of health? What does that look like? You know, this will come. We've got the data that shows that if you invest in the social drivers, it will reduce the total cost of care, it reduces inpatient admissions, it reduces emergency department visits, it reduces length of stay, because you're attending to what matters most. We set up people to fail every day, right? Mr. Gushnervich, your hemoglobin A1C is 13, right? And you come back and it's still 13, but we never ask, why is it 13, right? We never ask, could you get your meds? What kind of food do you have to eat? They're deeper questions, and we've got to start asking those questions. And they're uncomfortable for healthcare providers to ask. Mm-hmm. That's the beauty of the community health worker model and for people in the community, because they understand those communities. But, you know, we all live in our healthcare world. I said one time, if you want a hospital to build a food program, we're going to build a cafeteria, right? And how well does that work in a community? So we got to change the way we think, because every person that I've seen wants to do the right thing. Every one of them. But they make decisions in the environments in which they find themselves, and if we don't change those environments, we're never going to improve their health.
So now from the academic side. No, but it's, I mean, that's what, again, my perspective, not gonna speak for all of you who've been immersed in it, but I mean, I feel like that's kind of our role and our drivers is to help support the hospitals and the local community and for change, whether it be research or, you know, our resources we can bring to the table. I feel like we're meant to help each other. You know, Memphis is such a, again, diverse place that I mean, there's ample room for help, improvement, support, and that's kind of what I feel like faculty and what School of Public Health is wanting to do, is saying how we'd like to partner, like how can we help? We'd like to help in any capacity, whether it be practicums, our MPH, we assign our students practicums, would be practicums, or grants together to get money in, whether it be federal, whether it be however it is. Like I know, and even helping train. I know we just got a grant for the Tennessee Department of Health, gave us a grant to help build training modules so that their own employees could learn how to do just basic regression. So even at their own quantitative metrics, they know how to analyze their day-to-day, their own data, without having to go find a statistician and take time to do it. So, I mean, I completely agree. Even with the new, U of M's new CDC grant of purely just teaching and helping to, how can we bridge these gaps? Not to jump to other questions, but I think that's the biggest thing is, like we mentioned earlier, making these connections and making the collaborations, across the different universities, across the different healthcare systems, across, all your different businesses. I think that's the way to make the improvements that you were saying. You're absolutely right, is to help each other and be able to data share or just how can we support, how can we help, what can we do, whether it be, again, grants coming in, you're absolutely right. So that's kind of, I think, where our drivers are of, there's so much here, and especially if we can do it in Memphis, then how is that not going to be a beautiful model for the rest of the U.S.?
Yeah, that's great. And actually, you segued actually to the question I want us to kind of land on it. We're already reaching the bottom of the hour. We recognizing that Christ community, and it's part of our mission statement that we're here to serve our patients and the communities in which they live. But that comes within that mission that the community and the community's problems are bigger than what Christ community alone can solve. We have to rely upon others. We have to pursue partnerships, and some of those partners are not healthcare organizations, and they may not understand or embrace or express a care, if you will, for some of the disparities that we have. How do you approach those local leaders to really persuade them, really is the word, to be a part of the table, and possibly do you even have an example of an organization where you brought them to the table that was not a healthcare organization? And maybe anyone who's already.
Yeah, I don't mind starting. So I know me personally, most of my collaborations across U of M have been either pre-existing, so with grants with Baptist or St. Jude. One of my colleagues used to work at St. Jude, now at U of M. But other collaborations I have at UTHSC have really been students coming in and saying, oh, you have an interest in this, I have an interest in this, can we get some sort of contract, can we get data together and work on this? I was like, absolutely, but I can speak probably more to a couple of my colleagues that have reached out to say, kind of, what are some examples of your community outreach that you do partner with? And I think one's a really good example would be youth villages. So one of my colleagues works with them, and she came to Memphis already having a desire for social justice issues and youth violence. And so that was one of the things. She reached out to them and was like, hey, I have an interest in this, and we have a problem, well, I don't say a problem, an issue with youth and being in juvenile detention centers, and again, housing instability. So she reached out to youth villages and was like, hey, I'd like to, how can we help incarceration rates? How can we help housing? And then just kind of even, it was her reaching out, but they were very willing to help. But again, they were like, well, we don't have any records of all this. And so even getting that on track. But I know for U of M, the collaborations kind of go both ways. It's been some faculty reaching out to local partners. Also, it's been, people who know each other. I've heard of Jim through other people, but knowing other connections, I'm sure Susan knows people at U of M, our Dean Josie, who just began. So sometimes it's, higher powers that be connecting and then it trickles down. Other times it is, if someone has an interest, look on our website or contact me and I'll help put you in contact with someone. If you have an interest and would like to help, or people, and networking almost, of contact me, or and I'm like, oh yes, I'm interested, I'm always interested. I don't have enough time in the day, but then I can then pass you off to someone you might have the expertise. But I think it's been, at least in my personal experience, it's been a very interesting mix of how collaborations have formed. Sometimes, again, through people who know people. Other times, strangers walking up and saying, I'd like to have help, and reaching out. And so yeah, I think that's the seed of everything, is we can get this network of helping each other out even though it may not be exact Memphis and Regional 1, but be like, oh, we maybe don't have those resources, but I can connect you with someone who does. I think even that is really helpful across all of U of M. U of M, I'm sorry, Memphis.
And Jim, what about you? I know you've probably done a lot of work with making relationships through the Pop Health Consortium among other capacities. You know, how do you approach those local non-healthcare leaders to bring them to the table?
Yeah, you used a couple of interesting words, non-healthcare, you know, and thinking about different types of leaders, community leaders, people in neighborhoods who are affected and are the real experts on what goes on in their neighborhood. I think both those kinds of leaders are important, aren't they? So, you know, I think everything you were saying about data and evaluation and really the academic sort of ability to assist organizations in tracking, but ultimately the people in the community are the experts on what we need to track, you know?
Exactly.
And I think U of M has been particularly great in helping to elicit those stories from the community and using focus groups, you know, various kinds of surveys, but to really find out what's important to the people in the communities we're trying to serve, first off. And so, I'm not sure if I'm answering your question.
You are.
So for me, a lot of it's about stories. If I want to convince leaders, it's better if I still spout out too many statistics, but you know, recent story from our health hubs. A woman came in who had diabetes for a couple years, and after a few visits with a health coach there, she said, I heard her say, you know, when my doctor told me I had diabetes, you know, he said, take, you know, here's a couple pills you should take. And that's all I heard. I was frightened, I was scared. I had no idea what I could do. But when I came to the health hub, it opened my eyes in a way I'd never expected. And now I know what to do. After working with my health coach and going to the support group and the cooking classes, now I know what to do, and I've lost 30 pounds. And my diabetes is now almost gone away. You know, and you know, to me, that really touched me and helped me see, wow, you know, this is not just about what happens in the hospital. So I think we can use stories, tell our own stories, but particularly give people in the community the opportunity to share their stories and to lead the charge.
I'll take a little surprise, I'll take a different tact. You know, when we started One Health, we just went through the Rolodex and called everybody we knew. You know, if you're in housing, you work for the fire department, or you were in the legal services. I think Jane from St. Jude was in the audience once, and you know, you've got to bring your authentic self to the conversation. Basically, what we said when we started this is Regional One Health is doing a terrible job taking care of the people you're serving. You know, I still had a job after that, but it was true. If somebody had been to the emergency department 234 times in the past 18 months, we're doing something wrong, right? We're treating the wrong problem. We're asking the wrong questions. And so when we talked to the community, we said, we don't want you to do any work. We're not going to tell everybody how smart we are about what you're experts in. We said, we need your help. And we said, can you just tell us who else needs to be in this conversation? Can we come and really truly understand what you do and what you need to be successful, right? Because if we're gonna be partners in this, we have to bring our best selves together. I mean, we don't want to be an expert in housing. We don't need to be an expert in food. There are housing experts and food experts and transportation experts and, you know, interpretive services experts, you know, but we need to give people room to say, look, you know, here's what I can do, but I can only do it for X number of people, right? And then our job is to set them up to succeed, right? So an example, we've got more than 200 very close community partners that we work with on a daily basis in each of the 15 domains. And so an example is we understood that there was a need to do something different about medically tailored meals. Could we deliver medically tailored meals to uninsured individuals who are homebound, right? So again, cafeteria mindset, no. So we said, who does home food delivery? So we called MIFA, and because they do Meals on Wheels, right? But it's for 65 and older, where our folks are under 65 for the most part. So we went to MIFA and said, how can we work together to develop a medically tailored meals program? And if I write a grant, what would it cost us? And so I wrote a grant, and we knew what the meal costs were, and we knew what it was going to take to do medically tailored meals. And then I pass 100% of the dollars over to MIFA. I don't take any kind of administrative cut, because then they put 100% of the dollars into serving meals for our One Health enrollees who are homebound. And we've served, just this past year, right at 1,500 meals to 17 individuals who are homebound with chronic and life-threatening diseases. And then what we do is MIFA and I share data so that when they're writing grants, they can use data from my program to say, here's what we did. They pull down more dollars, then they can serve the greater Memphis community, not just the One Health enrollees. But you have to be able to say, we all bring something to the table. Let's figure out a way just to set a longer table, right? If I need another table to bring more partners in, that's what we do.
And you're really extending that table into the community.
Yeah, exactly. Because we're all taking care of the same people. Let's just call it out like it is. So, anyway.
Yeah, I'll tell you. And when you collaborate, it works. In with a success story for us, talk about the high utilizers, behavioral chains. I used to call them the Mama Jeans, from using some of the analogies of grandma and mom always cook with Crisco to make this gumbo, and they live to 90, why do I need to change? We would face that all the time in Louisiana, so you literally had to work with the patient to take steps toward moving them from Crisco to canola to olive to we had a patient at Christ Community who was averaging, let's say in a 90-day period, 113 visits to the hospital. The math is right. That means, yes, on average, more than once a day. And had a lot of social driver issues, no stable housing, no job, no family support. I don't know what health plan did not call us to try to help them keep her out of the hospital, the emergency room. And through our community health workers, or community health navigators that are sitting in the hospital, and our social workers, and with a lot of hours from multiple FTEs, we received a picture from that patient and a text. Actually, Shayla knows that person at St. Jude. She worked with that person, where it was a picture of her working at a job where her whole life was around. She was on her behavioral health medication, so you could tell she was conscious of her personality. She was getting healthier because she had a job and income and the means to afford her medications. She was proud of the fact that she was paying for her housing and she was paying for her food. So talk about individuals having not only a sense of involvement with their decision making, but we position them to demonstrate that they'll actually make those right decisions. And she just said, she basically told us thank you while she was there working at a restaurant. And so when you are investing these hours of time chasing these individuals, sometimes you don't know, and working with community partners, because it was not just us trying to find this individual housing during the turnaround in behavioral health. It's amazing to get that outcome. And yet, that was one person that we spent dozens of hours on. We need one another in order to turn around community health issues. So with that, I just want to say thank you to this team. I'm sure this is just a part of the dialogue that many of us are a part of. And if you could you just extend the gratitude and thanks to the team? With that, I'll turn it back over to you.
Thank you so much. I appreciate your comments. All of you, all four of you, have brought a lot of information to us tonight. we want to spend about 15 minutes opening it up to where you can ask questions that you may have thought of or that you may have come with for our esteemed panel. So who's first?
I got a question.
Wendy, go ahead.
This is not really, I don't know if it's really on point for, but when you talk about listening to patients, like, and listening to people and understanding, like, they're more than just the data that you're looking at. Has any read People's Hospital yet? A book called People's Hospital? I would highly recommend it. It's written about a hospital in Texas and about the experiences that this one physician encountered, and it was like they delivered really impactful and really high quality healthcare in an environment that was, you know, very underserved and underfunded. And it was interesting because it was about their connection with their patients. So anyway,
People's Hospital.
the People's
Yeah,
Hospital.
we're all writing and
Yeah.
everybody.
Yeah, check it
What's
out.
the one from, there's one from, that was about California housing and wraparound services, House of something. Does that ring any bells?
There's a one out of North Carolina called the 100-story home.
100-story home.
Yeah, it's out of North Carolina where they saw there was this need, but everybody was so siloed, nobody could figure out how to build something that could meet the needs of the community. And it's told through the voice of not the lady who just had the vision, but one of the homeless gentlemen that she had run into in the soup line at her church. And he says, you know, part of the first step to listening to people is, you know, acknowledging them, that they've been seen. He said, people walk by me every day and never see me, and so taking my time.
Yes, Al.
I'm original. I grew up in Brazil. I was a low middle class Brazilian. My neighbors went to bed hungry every day. We went to school together. But I think the biggest impact I've ever experienced in Brazil was when, I don't know if you've ever heard about street kids in Brazil. They were killing people, and we had a serious problem in this neighborhood. There was this gentleman that had a restaurant, and one of the street kids threw a rock inside that restaurant. Long story short, that rock transformed the community because they start asking the question, why did that rock hit the restaurant? Those kids were hungry. Their parents had no job. The community, 3 to 5 to 6 homicides a night. And in a matter of 5 years, that community was one of the safest communities in the entire region. And the reason why it happened was because of that one rock, and somebody decided to listen. The government started asking the community. You're talking about IBM, you're talking about the biggest multinational companies came to that neighborhood and they wanted to be part of the change. Yesterday, I was in Jackson, Tennessee, actually Tuesday, at the African American Conference for the West Star. And we were talking about challenges and opportunities with the Ford plant coming to the neighborhood. And one of the words that they said was readiness. My passion is helping independent healthcare professionals stay independent and be able to be part of the solution. So my question to you is, how can we involve the independent professionals like pharmacists that are disappearing? I manage pharmacies, and my pharmacies are dying, and they're trying to do the right thing, and they can't. So how can a health system, with the power that you have, help those folks be part of the solution?
Yeah, well, that's like solving world peace right at the moment. So it is doable, but you have to take a community, I mean, you have to work at the individual, the kind of independent system level, and you can look at an independent provider as their own little microsystem, right? And you start working together to help understand what resources are available, right? Because, I mean, I go back to health days, you know, we used to think all the pharmacists sat in like Walgreens and CVS and all of this when we were trying to roll out vaccine, and then we realized, oh, there are all these independent pharmacists that are out there, but we had to create an equitable playing field for everybody so that everybody had the same opportunity. I think one of the best ways is in sharing knowledge around how do you build a business case or a value case, and it's not always just dollars. If you do the right thing, kind of the money follows, and so it's how do we think about doing the right thing. That's what we learned in One Health. So we've got independent providers who actually, we don't require people to come to Region 1 if they're in the One Health program. We've got folks that go to Christ Community and folks that are at Alliance and all these places. But that's good for everybody because we're learning from each other. And, you know, I'd like to be able to solve the pharmacy issue, but I don't think I can.
Well, yeah, I was, you had a suggestion.
Yeah, I work for McKesson, and I'm the director of enterprise analytics, and I support independent pharmacies. And we have a franchise, Health Marts, and there's 4,600 locations across the country. And part of my job is to provide tools for these pharmacy owners so that they can compete and run their business well because they didn't go to school for business. So this is one of the ways McKesson is working in that space, and so I'm working with data, and I'm providing tools for these independent pharmacies. So.
And the other piece on the data is the data tells the story. Doesn't matter what it is, you know, but if you can get the data and if you can solve, I mean, the biggest challenge I think, or thing I learned in government is there are a lot of solutions floating around looking for a problem to solve, right? That's what are called bills in the legislature, right? But what the real art is really how do you dig down to figure out what problem you're trying to solve. And once you do that, the data paints a very beautiful picture, but we're terrible at displaying data in a way that
So
people
we're using
can understand
data science
it.
to locate
Yeah.
pharmacy deserts.
Yeah.
And to try and understand where to go buy some of these independent pharmacies that are about to like go out of
Yeah.
business, where we can help, you know, find new owners for these different pharmacies and keep them in business. So it's one of my.
Well, I think another way of thinking about this, because I don't know the pharmacy industry that well, and though I know some of the plight of independent pharmacists, but I think starting with our community needs, you know, and then thinking together as a community, what can we do together to you know, really build business around supporting those needs, right? Or addressing those needs. And I think just one example that we were talking about today is food deserts, right? You know, it's sort of disingenuous to, you know, have cooking classes and diabetes education classes if people don't have anywhere to get the foods, right? That are essential to human health. Thinking of the work of the works, and actually one of our partners with the health hubs now is Cash Saver grocery stores. And they're helping supply food at wholesale cost for distribution to a variety of mechanisms closer to the neighborhoods where people live. Well, that's the kind of solution that a Kroger and Cash Saver and what other grocery stores in our community, Superlow, could get together on. You know, when they start thinking about a common solution where we can help support small grocers closer to home in neighborhoods, provide healthful, make available healthful foods in conjunction with opportunities to learn how to prepare those foods and making, you know, with a focus on heritage foods for our community, then you're starting to think about a solution that can build demand and have some financial sustainability.
A model for that has been Walmart. You know, I'll think about big Walmart superstores, right? But they've got these little mini express Walmarts that do exactly that. They go into these, you know, communities of need with basic services. so that people can have access in a different way.
Checking on time. We are getting really close. I'm going to close this out, if I may, with one question. So we've talked about a lot about what our health organizations can do. What are ways that we as individuals on our time can do to be involved, to help improve the situation?
It's kind of like security. If you see something, say something. I mean, we've got opportunities in our organizations, but a lot of us are so big that it's like the homeless man that nobody sees. We see it all the time, but we just don't recognize it. So pausing and taking stock of what you see in your community, that's the first thing, right? Because there'll be some innovative idea that will come from that. You know, figuring out what's your passion. Are you passionate about food? Are you passionate about housing? I mean, is there something you can do in your faith institution that, you know, because a lot, I mean, this is a very faith-driven community. So are there opportunities to create even small programs around just basic needs?
Volunteering,
Clothes,
yeah.
foods, volunteering. Looking at organizations who are serving those that are disadvantaged. You know, you've got MIFA's got volunteer, I mean, everybody's got volunteer opportunities. But again, you know, you can't be quiet, you know, and if many of you go to these shindigs and there's gonna be a legislator there, you know, that's a great time. Get your 3-minute elevator speech together about why, whatever it is you care about, why they need to know about, that they're gonna go home and say, I need to call them, or making a call to your legislator to say, you know, I'm really an expert in filling whatever blank you want. If something comes up for you that, you know, during the session, let me know. That can be at the local level, it can be in your schools, you can get involved that way, but not getting involved in not calling out the injustices that exist in not just this community, but this world. Shame on us for keeping our mouths shut.
Well, we in healthcare, we see the needs,
Yeah.
right? We see the needs, we see the unnecessary amputations from untreated diabetes in the community. We see, you know, the hard side of lack of prevention in primary care. So I think in our day-to-day jobs, we can do a heck of a lot. So I know, Scott, you do information security. That's essential to data sharing, right? Is having a shared community data sharing information standard. Being one of the people within your organization that works for collaboration with our social services organization, that works for building those connections. And then I think all the things you said.
Yeah.
You know, maybe it's just
Awareness, yeah.
one organization that you get involved in with deeply that extends the work of your organization into the community. Whether it's, you know, it's getting involved with food pantry event that you do once a month, you know, with the Rotary Club, you know, working with Memphis Food Bank, or around, you know, you mentioned so many of those. So I know if we asked you, I've been wanting to ask you guys questions, but I know that all of you are involved in your churches and in organizations. Many of you are involved in organizations that do that kind of work, serving on boards. That's hard work. It really is hard work, and getting out of our silos is really hard work, but God knows we have some opportunities.
Yeah, no, it's just kind of more along the lines of you of you know, awareness is half the story, because if you're seeing it or not saying anything, you know, you've got to make it aware for it. You got to make it a shock factor almost to get attention of people, especially not in the health, even public health world in general, and I say that very loosely. You know, whether that be just volunteering or, you know, something as small as, recognize them on the street and then be like, oh, what can I do to help? Or what can I do for this? I think that's the biggest thing is awareness of it and bringing attention to it. Because otherwise, nothing gets done if no one's gonna know about it, so.
You know, knowing that processed food is one of the major drivers of the epidemic of obesity-associated conditions in our community, just thinking about what your church serves at lunch, you know, how can we create more communal food opportunities with our diverse neighbors that involve delicious and healthy food? You know, that's not easy to do, but it is a nut we can crack, right?
I'll share this, you know, in Louisiana, we were there a long time, so we were able to really make an indent. We're excited about being here. And so my wife and I, we learned that when you have frustrations, oftentimes it's probably a passion for you to do something. Oftentimes you're bothered and not others because it was meant for you to not only see and say something, but maybe start something. And so we went to our pastor at our church. We were in North Baton Rouge, very similar to the Westwood area here. And, you know, we were just very frustrated because we had lost our grocery stores as well. And so what my wife and I did was we found out that there was a food pantry that was not being judicious with the distribution, and that the USDA was coming to shut it down, and our community needed it. And so we sat down, we quantified our work-life service balance hours, quantified our hours to make sure it didn't break family, right? You have to be honest with what you can actually do. And we realized the hours that we could expend, that we may be able to help. So we actually took over that food pantry for 3 years before we moved here. And we moved it from just injustice in its distribution to people who they knew through a church, believe it or not, to not only growing that program, but actually getting to the place where we could get dairy and fresh produce. And if you know anything about a food pantry, you have to prove what you can do with the processed canned stuff in order for the USDA to consider you trustworthy to have fresh produce. And when I can think of people who walked in, not only that we served, they turned around and said, how can we help volunteer? And so when we needed help, they were actually willing and waiting for us to ask them to help. They actually started running it. And so don't just see or say something. Sometimes it might be you to start something, and then there's different forces and powers depending upon what you depend, but when there's a will, there's a way. And oftentimes there's ways for that to become sustainable, even if it's bigger than you. And so I just want to share that. So now we're looking at what we're going to do here. Serious, because there's some of the same problems. So quantify what you can do, be realistic so that you can commit to what you commit to, and serve.
Yeah, I think you hit on the key thing. There's always something you can do. We always say, well, we can't do that, but you got to change that sentence and say, what can I do? I may not be able to do everything, but baby steps. You know, it's kind of like a ship and the rudder on the ship. It just takes a little turn of that rudder, and an ocean liner will turn great distances in the ocean. You need to find the rudder. What's that little thing you can do to start those major moves?
Well, great. Thank you all so much. Appreciate it. So grateful to you for coming out and sharing your wisdom, sharing your insights and your experience. I thank everyone here for coming tonight and supporting us. Our next meeting will be May 18th. That's a Thursday. And the topic is
Strategic marketing.
strategic marketing. Thank you.
Winning the battle for markets and share.
I couldn't pull it out. So thank you so much for coming tonight. And once again, I will be sending out to your email addresses a link to our survey so that you can help us improve the future programs. Thank you all. Have a good night.